the politicians don't react until they see the hurt. And we don't want to see the hurt, so we need to be able to educate them on the actions that will need to be taken.
Welcome to Rural Health Today. I'm JJ Hodshire, President and Chief Executive Officer of Hillsdale Hospital, and this is a podcast where we connect you, the listener, to what really matters the most in rural health. I am so excited to introduce our special guest today, Rick Pollack, President and Chief Executive Officer of the American Hospital Association. And the AHA has been very busy recently. Obviously, the national news that has been at play here since really mid-March. Rick Pollack has probably lost a lot of sleep, spent a tremendous amount of his time advocating across the United States. He's been everywhere. In fact, I had the great opportunity to meet with him several months ago in Lansing, Michigan, when he presented to our board at the Michigan Hospital Association. And Rick did a phenomenal job at outlining what's at stake, what's at risk, challenges, and then opportunities for us in rural communities like Hillsdale. So first, Rick, let's start with a little bit about your background. I was absolutely fascinated. I didn't know your background until we had dinner that night at the Capitol Grill, and we were talking, and it was really incredible to hear what you've done and where you've been and how you even got started. So I want you to tell that story, if you would. How long have you been at the AHA, and what brought you to that organization to choose that field?
Yeah, well, thanks first for having me. I really appreciate the invitation to be with you, JJ, and thanks for your leadership. I mean, you've been a real voice for rural healthcare in this country. Of course, I know that you've been very involved at the state level as well in Michigan, and we appreciate all of your great leadership. But, I was a political science major in college. I attended the State University of New York, and for many of you that may be familiar with the SUNY system, we really don't have a flagship. We have four universities centers, and we have 8 four-year colleges, and then, law schools, medical schools, and community colleges. I went to one of the 4-year arts and science schools, and they had a Washington semester program. And I was selected to represent my campus in that program, which still exists today. I mean, this was in 1976.
Wow.
I was assigned to work in a congressional office as an intern my senior year. And it was a rural community, by the way. It was Wisconsin, and it was from Wausau all the way up to Lake Superior. And very much a dairy farming community or congressional district in many ways. But anyway, I had worked as an intern there and went to graduate school for public administration at American University in the evenings. And ultimately, I was hired and became a legislative assistant and worked for about 6 years for Congressman David Obey. He had stayed there for a long time. He retired about 7 or 8 years ago, eventually became chairman of the House Appropriations Committee. But the point and the reason I raised that is that was my entry. And then since he was fairly young at the time, he was in his 30s, as a career for Washington and Capitol Hill, you want to work for a committee. And that wasn't really on the horizon. So the other alternative is you become a lobbyist. And I became a lobbyist for the American Nurses Association. And I really didn't know very much about healthcare issues. I did education and labor issues. And it was on the Appropriations Committee that he was ultimately the chairman of. But, the Appropriations Committee in the Congress is its own subculture. Even today, it's very different. It's more bipartisan than anything else. And the Nurses Association at the time just wanted someone that knew how to get them money. And that was what we did in appropriation.
Yeah.
And then 43 years ago, I came to the American Hospital Association as a frontline lobbyist, then became VP for legislation for 24 years, or executive vice president for advocacy and representation for the last 10, CEO. So that's been my journey, if you will. And I've always said that, as someone that came up through that role, I could sell anything, but it's very special to be able to be an advocate for hospitals because of this very special role that they play in society. And it's a real honor and privilege to say that I do that.
Yeah, it is. you've done an incredible job. To say you're a champion would be an understatement, but you've been a champion for healthcare. You have, what I appreciate most about you, Rick, is that you're not just focused on big health, big systems, the ability to integrate rural hospitals, critical access hospitals, big mega systems. The list goes on, and be able to balance all that. You have done a remarkable job at that. And I know that, one of our team members and friends, Brian Peters, who is a board member of yours, and I serve with him on the MHA. We have talked numerous times, and he sings your praises each and every time that we get together, because there is a tremendous amount of work that you're engaged in. I want to talk about that today, Rick. I want to really jump into the issues at hand. I know we got a very limited time with us here, but today we're talking about what happened in the Senate last week regarding the one big beautiful bill, the approval and the signature by the president, and its impact on Medicaid funding, specifically to rural health. And the largest news on the bill is, of course, it's still fresh. We're still analyzing it. I've got a call even this week with some MHA friends discussing the impact timeline, those type of things, a lot of unknown. But we're excited here on Rural Health Today to have Rick to explain from his perspective what's going on and share, as a leader of the American Hospital Association, what we can review, look forward to, have an idea about. Is there any hope in this? And what is our, option as we look at trying to repeal some of this dangerous legislation? So we'll look at a high-level overview, impacts for rural hospitals, and, of course, what does all of this have to do with rural health? So, Rick, let's start with a high-level question, all right, and an overview. I was fascinated to hear your perspective a few months ago about what it's like in D.C. You've been there now for decades. So could you explain what it's like right now? And then in comparison, it's changed over time, but also in the last week, it's been very heavy. Could you talk about both of those?
Sure. I think that, the environment that we're in now is one that is obviously highly partisan, to say the least.
Yes.
And it's, dominated like never before by a president, and especially President Trump.
Right.
And what we've seen is really a very high level of unpredictability. And it's not just around healthcare. You think about the world that we're in today. Yes, it was the big bill, but it's also the uncertainty with regard to executive orders and the challenges in the courts that go back and forth.
Yes.
There's uncertainty around the economy related to just tariffs that have an impact on medical supplies and medicines. And then, of course, world affairs. So in general, things are just very unpredictable. The second thing is that, I said it's very partisan, and we have a trifecta, and that changes the dynamics. Every time you have a trifecta, it's inevitable, no matter whether it's Democrats or Republicans. And JJ, we're a bipartisan organization. We'll take help from anybody that will give it to us.
Absolutely.
But anytime there's a trifecta, the party in charge tends to overreach. Yeah. And then there's a reset. And you've seen this consistently. I can go through it over just the last 30 years. Yeah. And that may be what we just saw. And that reset often comes in the midterm or the next election. It's true. And very true. In fact, see that. When it comes to policy and health policy, and you just saw this play out, we didn't make health policy here. It was budget policy. Whatever was done to achieve savings that became an offset for the president's domestic policy agenda, whether it was to extend tax credits and expand them, whether it was to increase border security, whether it was to provide more resources for defense. That was what we were involved in, or what we got caught up in terms of health policy. And the health policy that's made is very transactional. It's all in the context of making the numbers add up and the votes add up. The other aspect of what we see going on here in Washington is that Congress seems to only act when there's a forcing event. And the forcing event for this big bill was the expiration of the tax cuts and the debt limit extension. We'll have another forcing event in September, which is funding the government, which is always an issue.
Absolutely.
And we'll have another forcing event that's going to get tied up in that, which is the extension of the enhanced premium tax credits that expire under the Affordable Care Act. So things tend to now move in big bills around forcing events.
Yeah. So Rick, let's talk a little bit about, so I loved your perspective a few months ago. You actually took us through the history. You spent about 35 minutes with us taking us through the resets. And it's important to understand that history and to know that most likely it's going to repeat itself in this particular situation. But, we have a time frame of a few years before that actually happens. And so the impact of this legislation on rural hospitals, I want to talk a little bit about that because, when we look at how this legislation is going to really eliminate or reduce what is known as the provider tax, we're not going to get too deep into all these issues, but this is where we as hospitals have, formed an alliance and a coalition to speak out against, because the provider tax is providing a mechanism for us for some average commercial rates within our respective states that allows us to be able to cover the cost of serving the Medicaid patients. And as you know, with the challenges we face in payers in general, but in rural communities like Hillsdale, 70% of my payer mix is Medicaid and Medicare. And the majority of that funding, of course, coming from federal programs or state programs that derive reimbursement or uplifts from certain things such as provider tax. So what was at play here was how those provider tax were going to be cut or even eliminated. And there was even suggestions at one point in the Senate bill that would pare this back to Medicare rates for Medicaid patients. So it took a huge hit for rural hospitals. Scott Becker predicts that over 800 hospitals are at risk of closing right now. We know that since 2010, 150 hospitals in this country have closed. That's going to be accelerated extensively, and it's going to have an exponential increase in closures over the next few years because we have a lot of our rural hospitals that are truly operating on shoestring budgets, no margins, and some, that are operating on margins, they're razor thin. And so all of that to say, from your perspective, how does this news in the Senate impact rural hospitals specifically by cutting funding to Medicaid? If you could just elaborate on that, I would be very grateful.
Yeah, of course. And let me just say that the outcome was a very disappointing and difficult day for us.
Yes.
Because despite months of clearly demonstrating the implications of what these reductions would have, particularly on rural communities where there are a lot of Republicans and a lot of Trump voters, and vulnerable populations, and it's a lifeline for rural hospitals. People basically said, no, we're going to go ahead and do this.
Yes.
Despite promises to keep it off the table. So this has been a disappointing outcome. But JJ, if I can just unpack it for you a little bit and put it into two categories in terms of the impact on rural hospitals. And by the way, obviously there's an impact on rural hospitals, but it affects all hospitals.
It does, absolutely.
But let's just talk about it in two buckets. There's one bucket that's the bucket of coverage, okay? And the fact that over 10 million people are going to lose health care coverage. And reasonable people can agree to disagree on whether there ought to be work requirements, whether non-citizens ought to be covered. And those two provisions alone add up to $400 billion in savings from a $1 trillion package, just to put it in perspective. But what people didn't really understand, unfortunately, and we tried to make them understand this, is that guess what? When people lose coverage, they end up in REDs.
That's right.
By virtue of the fact that there's federal law and our mission. We take care of everyone that walks through our doors. We become the family doctor to the uninsured. EDs get clogged up, longer wait times, forces a reduction in services and potential closures. And we made all of those arguments. But one of the arguments that we also made was, guess what? It doesn't affect just Medicaid beneficiaries. It affects everybody.
Everybody.
Everybody. And for rural communities in particular, when a rural hospital is not there, there is no access point, period.
Right.
And that means that the community has a lot of, is under a lot of strain in terms of lack of access, and businesses don't want to locate there. So
No.
coverage is one piece of this that can not go unrecognized as something that's of enormous hurt. The second piece is what you talked about, which is provider taxes and state-directed payments. And those two, the restrictions on those two areas, we were concerned that they were going to eliminate them all. And I can talk to you about the history on that one. But those are over $300 billion in reductions over a 10-year period.
Yeah.
Now, both of those don't go into effect until 2028.
Right.
Which is interesting because if you want to lay the predicate for revisiting the overreach, how you do that before it even hits is a challenge that we have to figure out, and we're working on right now.
Right.
Now, I say that this issue has been around because, I remember testifying as far back as the George H.W. Bush administration when they started to look at these state provider taxes. Both Democrat and Republican administrations, from a federal perspective, have been very critical of these approaches for years. And part of it is because they don't think from a federal level that the states are stepping up to the plate to provide enough of the Medicaid support that's necessary for the partnership that this program represents. Now, we, of course, have said that the provider tax programs and the state-directed payment programs are patches on a fundamentally broken program that severely underpays us less than the cost of providing service.
Right.
And in the absence of these mechanisms, which we wouldn't want to do in the first place, but we have no other choice because it holds a program together for our most vulnerable patients and communities, needs to be retained. And at the end of the day, they were restricted. They were maintained. In 2028, the provider tax for the expansion states basically frozen. If you're a non-expansion state, it reduces from 6% cap to 3.5% in increments over a 5-year period. For state-directed payments, whether you're expansion or non-expansion, it's going to be reduced from however you define the average commercial rate.
Right.
A lot of different definitions.
There is.
Either Medicare or 110% of Medicare. The expansion states get 110%. The non-expansion states get 100%.
Yeah.
Now, one of the interesting things, JJ, about this legislation, and you saw it emerge on the Senate side, this was a Senate issue, is a real differentiation in treating expansion states differently than non-expansion states. Yeah. And, of course, Michigan is an expansion state.
It is.
But I know this is a broader audience. But what you saw playing out here was the view that the expansion states got a lot of federal money because they expanded Medicaid.
Right.
And the non-expansion states were hurt.
Didn't.
So we're going to give preferential treatment for the non-expansion states. Right. And, oh, by the way, Republicans in general are still not the biggest fans of the ACA. And while they didn't repeal and replace the ACA in this bill, they did a couple of changes through the back door that essentially disassembled pieces of it.
Agree.
But their view was, we don't want to give non-expansion states an incentive to expand, and we're going to give preferential treatment. So that was one of the underlying things. Last point. One of the things that they did do in recognition of all of the concerns that we generated around the particular impact in rural communities was establish a $50 billion fund for rural transformation grants that will go to the states over a 5-year period. Now, that's good, but in the scheme of things, it's not adequate to address the potential gap that's created from a funding perspective here.
Absolutely. So, you cut off both my arms and you give me an extra toe. Who do I say thank you to, right? I mean, at the end of the day, what we're addressing here in rural America is the, overwhelming challenge of margins as it is today. But we're serving programs like obstetrics, right? And across this country, OB centers in rural communities are closing. And the cost of, doing business for a high population of Medicaid patients is often challenging, especially when we still have individuals in our respective rural communities who are not going to the marketplace to get insurance. There's the uninsured. We haven't even addressed the uninsured that still exist in our communities. And in rural communities like mine, it's called the Amish. It's a population of individuals that have no health insurance. They live in communities and they utilize services, and they either try to pay for cash or they don't pay. And this is indicative of what we find. But I think the key challenge and concern is in these rural districts, and I'm saying this, I'm not speaking on behalf of Rick Pollack, but in rural communities like Hillsdale, our congressional district is comprised of all rural hospitals. And there's a few big systems that are intermingled in there that have a rural hospital. But at the end of the day, those hurt by this legislation, voted upon by a Republican representative, my friend, who I have ran campaigns for myself, very disappointed because in his district, every one of his rural hospitals have been identified as potential risk of closure, with one of those at immediate risk of closure. And so the impact on the economy is what we also have to keep our eye on, like you just indicated. And it's about businesses that want to relocate to have healthcare services. So all of these challenges are paramount. We're trying to negotiate with payers outside of even Medicaid and Medicare, of course, because we get what we get. But then we're trying to go to the table with Blue Cross Blue Shield and other payers, and all of these tumultuous challenges. At the same time, labor costs are increasing, tariffs are on the rise. All of these concerns are facing rural hospitals, and it's creating one of the most perfect storms that would create these closures. So in light of all of that, what advice would you give? You've got 4 decades of this. What advice would you give CEOs like myself, who are doing this work right now? What should we be doing to prepare for this bill to go into effect? And, I guess what questions should we be asking to try to communicate to our board, to our employees? Could you give us some help and some direction in that area?
Yeah, I think, people have to, I think, everybody's doing contingency planning now, and people have to communicate to folks what is going to be necessary to hold things together under the current environment that we're in, and what the consequences are. Elections have their consequences.
Mm-hmm.
To your point, we're doing the best we can with the people that are sent to us.
Mm-hmm.
And in this case, this was a very partisan process. In the House of Representatives, it passed with only one Republican, well, 2 Republicans voting against it on a 1 or 2 vote margin. In the Senate, 2 Republicans, both of whom we were focused on, opposed it, and a third for different reasons. So, we were very surprised because, again, the constituency that we were very focused on making the arguments to were Republican constituencies, many of which are Trump voters that are beneficiaries of these programs.
Absolutely.
And I think that people need to be accountable. And the way to do that is to basically share with people what is going to be necessary in terms of planning for reduced services, hopefully not closures, but other tough choices that we're going to face to remain viable as an access point in the communities that we serve. Education is going to be really important here. Now, one of the things that I mentioned before that's a real challenge is that while it doesn't take place until 2028, we need to educate people as to the potential scenarios that could occur. Because in the political world that we deal with, the politicians don't react until they see the hurt.
Yeah.
And we don't want to see the hurt, so we need to be able to educate them on the actions that will need to be taken unless they come back and they work with us in a way to mitigate some of these things. And that's going to be key. It's really educating people on the different scenarios that we're faced with, the tough choices.
Yeah.
In some respects, one of the things, and it comes to mind because I've been a part of this for some time. I would take people through an exercise and basically say, if you were in our shoes, here are the options.
Right.
How would you handle it?
Right.
What do you think ought to be done in terms of the options?
That's right.
I think that's a very educational exercise to put people in our own shoes.
Agreed.
And invest them in the issue that we're dealing with and make them understand, what needs to be done.
Absolutely. I think, boardrooms across the country are going to be very, very active and busy. I would encourage those listening who are board members of hospitals across the country, don't give up. We have to stay strong. It doesn't mean giving up and closing your hospital or selling your hospital, looking at new ways, very simple principles of reducing our cost, increasing our revenue to serve this population that we need to serve. It's the right thing to do. I think also we can't lose sight that during the conversation over the next few years is the fact that the American voter who said, 60% looks at Medicaid favorably. Also at the same poll released by, KFF, they made it very clear that the majority of voters that had taken that poll, and so individuals at 83% of those that responded said they did not want deep cuts to Medicaid. Congress is going to have to answer to that because the American people have made their voice clear that they don't want deep cuts, and that's what these are. These are very deep cuts that are going to be really placed on the backs of hospitals and providers like myself. And I just want to make one last comment, Rick. Your team did a remarkable job during this, pushing out education and awareness. From the faces of Medicaid, the storylines. Your team was incredible. I mean, we took our lead from your team, and it was incredible. The work that your field reps do on the ground, Dan and others, it's incredible. And so seeing the faces of Medicaid, we're talking about the farmers, the pastors who get Medicaid. We're talking about the store clerks. To coin the lazy or the 27-year-old playing his video games in the basement isn't what we're seeing in rural America. We're seeing individuals who are trying to work very hard, but we live in a community where small businesses of 20 and 30 employees don't offer health insurance. So we're going to keep all that in mind as we move forward, is that the American people didn't want deep cuts. It happened. So we'll see what the next few years brings. Board presidents, hospital presidents, listen, we've got to hunker down like we never have before. Last question for you.
And I was just going to say, getting back to, what people need to be thinking about, listen, there are always operational efficiencies that can be achieved, and we're going to provide the resources and the options in terms of things relative to financial strategies,
yes,
relative to care delivery transformation, relative to how technology can be employed to address some of these issues. So there are things we can do to further tighten our belts that we're always looking to do.
That's right.
But closing this gap is going to be definitely a major challenge. And, getting back to the politics of all of this, the counter narrative, which ultimately prevailed, was all about fraud and abuse.
Fraud, waste, abuse.
Right. And a lot of people in the administration and on Capitol Hill, thought that, whether it was work requirements, non-citizens being eligible for the program, or state-provided taxes and supplemental payments, they put it in that bucket, and ultimately that was an argument that they made, and our counter arguments, unfortunately, didn't prevail as a practical matter.
I shared with a news outlet just last week. It's spin doctoring at its best, and unfortunately, it was on the backs of hospitals and providers. So, I'm going to encourage our listeners that if you are not part of the American Hospital Association, and this isn't a shameless plug, trust me, and this wasn't requested by HA, you need to join your local state association. We in Michigan can boast that we have 100% participation from our hospitals throughout the state of Michigan, but also become a member of the American Hospital Association. We need resources. And I want to tell you, the AHA provides a tremendous amount of resources to hospitals like Hillsdale and committee work and conferences, and the list goes on and on. So I'm going to encourage it. So last
Can
question.
I just also say, you have a great state association in Michigan in particular.
We do.
Brian Peters, as you mentioned before, is a wonderful leader. But also, we were very strong partners with the state hospital associations in this whole effort.
Yes.
We were unified around what our narrative was, that we talked about the faces of Medicaid, the rural lifeline, trying to debunk these notions of its fraud and abuse, trying to make the case that it will affect everyone. We were very unified around the political targets that we really wanted to be our champions.
Yeah.
And you saw it play out in the Senate. Senator Tillis, Senator Collins, that voted against the bill, that were champions for us. There were others that helped us mitigate. And also, we had some priorities going into this from the get-go that I know that you were a part of discussions with at the state level. Number one, we wanted to make sure that there weren't going to be block grants or per capita caps. And we didn't want them to change the core FMAP. And we knew that the state-directed payments and provider taxes would be a fight. And we ultimately wanted to make sure that they weren't wiped out. One of the dynamics in both the House and the Senate is the people that were opposed to both bills. Many of the people that were opposed to them were opposed because it didn't cut more.
Correct.
They wanted to cut more. And we can never again forget that it was a unique set of circumstances where this bill was carrying the entire domestic policy agenda of the President of the United States and the Republican Congress. And, it was not a health bill. It was really a tax bill. And, it was using a very sharp tool called reconciliation.
Yeah, absolutely. Great perspective, great insight. The last question I guess I'm going to frame is relative to you've been around for a while, and you have seen administrations and various Congress approve legislation that is at some level 2 to 4 years later attempting to be rewound. And I guess the question is, for clarity of our listeners, this has passed. We will look at a 2-year stretch, but how likely is it that even in 2 years we're going to see a reversal of all of these things? What best can we hope for in that process?
Well, I go back to the 1997 and the Balanced Budget Act of 1997. There was a clear overreach back then. And for 3 years in a row, there were what we call BBA give-back bills, because they knew they went too far. And we demonstrated the hurt. In fact, we used to do, faxes were the thing back then. We used to do a fax of the day, and it was called Fax Update, and it was called Real Pain for Real People. And it was stories about the impact at a very specific level. And that sustained us for 3 give-back bills. And then 9/11 hit and the world stopped, even though we were on to a 4th one. But, that was a different era, JJ. We had a balanced budget back then.
Yeah.
And it was a little bit easier to create that kind of dynamic. Now, it's a little bit harder because we have a significant debt in this country. We don't have a balanced budget by any stretch. We just added money to the deficit. We don't have the immediate hit. So that's why it's so important to use the scenarios in terms of demonstrating what will happen unless they step in to mitigate.
Absolutely.
Now, in reality, when we talk about mitigation, there are all sorts of dials that can be dialed to mitigate, including the year that it takes effect. It's 2028. And then, is it 3.5% or is it, 5.5%? And is the schedule that the phase-in occurs at the schedule that occurs, or can that be changed? So there are opportunities to change the dials in a variety of different ways. But the ultimate challenge for us now is education on what we will need to do to make it work and the consequences of that, to make them understand that there will be consequences. They may consider it unintended, but whatever it is, it's going to need to be addressed.
Yes, it is.
And the stories about how it will affect people at the local level is absolutely critical.
Absolutely agree. Rick, you're doing a fantastic job. I really appreciate the work that you and your team have done to support hospitals like Hillsdale and associations like Michigan Hospital Association. I can't thank you enough. I look forward to, working with you in the years to come to tell our story, to unite our voices together, to fight this, and to really return back to our rural communities what is so important, which is care, and to make sure that, we can create places where these gaps can be filled and where there are going to be no deserts of care, whether it's in obstetrics or psychiatric care or whatever it is, where the high incident rate of those Medicaid patients are, that we can continue to operate as we are. So I really appreciate you joining us on Rural Health Today. And we like to wrap up each of our episodes with a segment called Rural Health Recommendations. And for every guest that we have on the program, we like to really ask them to contribute a recommendation on rural life healthcare. And it could be, a tip for someone who's just brand new to leadership in rural healthcare that's like, what did I just sign up for? Or maybe it's some sage advice on thriving in a setting that can be rural. We'll add each recommendation as we do, and we put this guide separate from our podcast just to give encouragement to those who are trying to fight the good fight. So, Rick, what is your rural recommendation?
Well, before I do that, I just want you to know how committed we are to work with all stakeholders to mitigate the impact of these cuts wherever it's possible.
That's right.
Because our goal is to ensure that hospitals can remain open for their communities and people can get care when and where they need it. And right. Our economic and our nation's health depends on it. Now, in terms of recommendations for the future, and in particular for rural hospitals, one of the things that I think is unique about the opportunity for rural hospitals is that not only do people in rural communities trust their hospitals so much, because they're your neighbors and your friends, you're very visible, but you make care convenient for people, unlike in a lot of other settings. And I think a lot of the future of healthcare depends upon making care convenient for people. And when you think about the future and you think about the healthcare needs in the future, so much is going. Half of surgeries today are already on an ambulatory basis.
Yes, they are.
The big spending on healthcare, the big need on healthcare is going to be managing chronic conditions for baby boomers like me, that already have a new knee and a new shoulder, and probably more to come. But my point is that rural hospitals are still able to do all of that. And people don't want to leave their community to get the care. Their support systems are in place. They don't need to run to the big city. And you are still positioned to provide that care in a convenient, affordable way. And I think we need to look at ourselves. We're so proud of the H and what it represents. But we also have to think about how we redefine that H and how we provide the care, not only in the building, but also in the schools and at the workplace and in other settings where we are positioned to do that. And I think that that's an opportunity for rural hospitals in particular. And I think that that's what we have to keep an eye on. We have to focus on creating networks of caring as an access point. And maybe the building will look a little different.
Excellent recommendation. Thank you, Rick. You've been just an absolute asset and a champion for us, and I cannot thank you enough. And I know that we'll be with you in this fight. You'll be with us, each of us. I just appreciate the time you've given us in the last 40 minutes to share your wisdom and as you guide us through some of the most tumultuous times in our environment and healthcare. So thanks for joining us today on Rural Health Today. It's been great to have you.
Thank you, and thank you for your leadership, and it's an honor and privilege to say that we represent you.
Absolutely. It's an honor to have you represent us. Thank you so much. And thank you to our listeners for tuning in to Rural Health Today. Catch our next segment, Rural Health News, to stay up to date on the current state of rural health care every Monday, wherever you get your podcast. Don't forget to check out our latest updates and resources from Rural Health Today at ruralhealthtoday.com, and make sure you've subscribed to the show so that you never miss an episode. Until next time, remember the power of rural.
Thank you for listening to another episode of Rural Health Today, the podcast where we connect you to what really matters in rural health. Rural Health Today is a production of Hillsdale Hospital in Hillsdale, Michigan, and a member of the Health Podcast Network. Our host is JJ Hodshire, our producer is Kirsten Newlon, and our audio engineer is Kenji Ulmer. Special thanks to our guests for sharing their expertise on the show, and also to the Hillsdale Hospital marketing team. If you want to submit a question for us to answer on the podcast or learn more about Rural Health Today, visit ruralhealthtoday.com.